I knew. I knew that it was cancer. Now I was going to be facing the very thing that I had feared ever since I was a 12-year-old girl, having watched my grandmother die from it.
You're trying to protect your kids, and you can't protect your kids from this.
Some diagnoses can change your life in an instant, along with the lives of the people you love. Today, astounding advances in precision medicine can offer new hope.
Diagnosing cancer can happen before the patient has even entered the operating room.
We're also now armed with new therapies that are safer, easier to take, and much more highly effective.
While the science of screening, diagnosing, and treating disease is changing at an incredible pace, we are struggling to change with it.
Right now, we're in this tough position where precision medicine is like a square peg trying to fit into the round hole of the existing medical practice.
There's areas of leakage that in some cases are chasms in which patients miss out on opportunities for treatment. Our business model has to change to address all of that.
KPMG is helping unleash the full power of precision medicine by supporting our clients throughout the ecosystem.
It starts with the research and development capabilities, going all the way to the launch of the therapeutic. It goes into the deals and the strategy that are associated with it. It goes into the integration and separation of different companies that surround precision medicine, and it goes to the performance improvement of our academic centers and our medical centers worldwide.
Across our industry, the changes we must make are massive in scale. But so is the impact we can have. Today, on patients facing life-altering diseases like cancer, and tomorrow, on future generations who may never have to face these diseases at all.
Okay, thanks for joining, everyone. I'm Alistair Milton. I'm a partner in KPMG's Healthcare and Life Sciences Strategy practice, and I lead our precision medicine practice. This is going to be the last session of KPMG's 2024 Global Life Sciences Summit, and I would say we've definitely saved the very best for last. Now, as you just saw from that intro video, KPMG has developed a cancer documentary that really tells the story of the evolution of precision medicine, and I'm delighted today to be joined by some of those who participated in the documentary and who you just saw in that teaser video. So firstly, I'll start with you, Terri. If you could just introduce yourself, please.
Yeah, hi, thanks for having me. I'm Terri Conneran. I live in Charlotte, North Carolina. I'm a 7-year lung cancer survivor and started the KRAS Kickers, a patient empowerment group.
Great. And then Gabe?
I'm Gabe Bien-Willner. I'm a physician scientist who spent many years developing next generation sequencing technology and other molecular diagnostic testing. And I'm also involved in policy writing and payer controls.
Okay, Bonnie?
Hi, thanks for having me. I'm Bonnie Anderson. I'm the CEO of PinkDx, a women's healthcare company, previously built Veracyte. And I've been doing diagnostics for 40 years, and I'm excited to talk about the diagnostic paradigm in precision medicine.
Great, thank you. And then Ed?
Hi, everybody. Ed Kim. I'm a medical oncologist, thoracic trained. My current position is physician-in-chief at City of Hope, Orange County. My prior lives have included over a decade in academic medicine at MD Anderson, and then helping build practices and cancer centers in North Carolina, and now with City of Hope.
Great stuff. Now we're going to show a slide here to kind of level set everyone on the topic of the panel, which is really focused on what we call patient leakage in precision medicine. And this slide is actually from a paper that was published a couple of years ago by the Personalized Medicine Coalition, and actually one of KPMG's alliance partners, Diaceutics. And what PMC and Diaceutics did was they used various public and proprietary data sources to show that only around 1/3 of advanced non-small cell lung cancer patients who really should get a targeted therapy actually receive one because a myriad of reasons, and what we could think of as leakage points. And it starts with the kind of the tissue journey all the way on the left, and various reasons. Sometimes we don't get enough tissue. It goes all the way to the far right of this slide where, sometimes for different reasons, even when the physician has the biomarker report, for different reasons, patients still don't get the appropriate targeted therapy. And this is in lung cancer, which is where we think of really as the poster child of precision medicine. We've had targeted therapies in lung cancer for many, many years. And so you can only imagine that these issues are much worse in various tumor types. So this is really to kind of level set everyone on these leakage points and the kind of the topic of the panel today. So I want to start with you, Terri. There's an element of the various leakage points that's kind of around patient empowerment, patient engagement, and education as well, and how critical that is to enable cancer patients to push their healthcare providers for biomarker testing when they're sitting in the office on first diagnosis. But actually, your belief in some ways is that education, that empowerment actually has to start even before maybe a patient has a diagnosis of cancer. Can you tell us just a little bit more about that?
Absolutely. By the time you're getting or walking through a cancer diagnosis, regardless of the type, you're just worried about survival and survivor now. Okay. You're in just this critical mass moment. And you're not thinking about flossing your teeth. You're not thinking about all those other things that kind of might have led up to whatever. You're just right now trying to survive. If we were able to have like just common vernacular around biomarkers, that knowing like these are things that might be looked at prior to a cancer diagnosis, then you know enough to ask the question about to your doctor. You're not getting an oncologist until you've been diagnosed with cancer. You've missed that opportunity to already kind of come in with an educational moment and learn about something prior to that diagnosis. So it'd be fantastic if way beforehand we refer to things not just as blood pressures and temperatures. Those are bioindications, right? But biomarkers in cancer, it's still a biomarker as we're starting to look at biometrics. And so if those biomarkers are walked into, whether it's education sessions through schools or just on the back of healthcare professionals' doors, it'd be fantastic.
The other thing I wanted to ask you about is something you've mentioned in the past when we've spoken. It's about ownership of data and access to test results. And I think sometimes you feel that the patient in the ecosystem is just treated not as an afterthought, but certainly isn't always thought of it as being at the center of the ecosystem as they should be. And you feel sometimes that you can't actually get access to some of the data that's being collected on you when tissue is taken. Can you talk a little bit more about from a patient perspective, what that kind of means for you?
Oh, yeah, absolutely. The problem is that everybody says patient-centric, and when they say patient-centric, they're inviting me to the dinner table, then I find out I'm the entree, and they're poking at me and taking pieces of information. I don't get to make my own choices. I'm just subjected to whatever is happening. And once that biopsy or blood or whatever leaves our body, we don't have any sense of ownership over it. And we own it. We feel connected to it, but the healthcare systems are not providing that information back to us automatically. Okay. I might get a copy of a biomarker testing. I might get a copy of my CT scan results or whatever. I might get the summary. There's no definitive biomarker test that goes back to my chart for me to be keeping track of. So there's not even anything for me to prompt my doctor with asking, or what does this mean? What does this say? Where can I get more information? And so there's not even that sense of checks and balances across the system. Quite commonly, many of the systems have it that my oncologist orders the testing, the oncologist gets the report, the oncologist keeps the report. I get to pay the bill. And I get whatever it is they subject me to.
Mhm. So, Ed, I want to come to you next. Obviously, just heard from Terri about the kind of need to educate and empower patients, sometimes even before they're diagnosed with cancer, so they can have the right information when they're sitting in front of oncologists like yourselves. We see in the leakage points that a lot of patients are lost because, frankly, physicians aren't testing and aren't necessarily following the relevant guidelines, which is surprising. But I guess in your opinion, what's gone wrong in the system when oncologists are not routinely testing for markers, and what can we do to kind of fix that issue?
Yeah, I think that is an issue, and I think when you look at this type of chart, it really identifies areas where there are gaps. Uh, Lung cancer is the poster child of precision medicine, and fortunately or unfortunately, it's also one of the most common cancers. And so we're not dealing with a rare cancer or an esoteric cancer where not many people know how to treat it. They're going to usually refer those very rare cancers to specialists. This is a common cancer. And if we look at how breast cancer was able to incorporate markers very quickly, it was because the tests done were able to be done by the pathologist in their practice. Here, we can't do that so much. And so you can see early on, there was a lot of emphasis on educating pathology, specimen evaluation, and biomarker testing. And you can see that the percent there, 798 to 784, really is not much of a drop off. And I would say that was very effective. The problem with the gaps that still exist now is just as you say, who is on the front side seeing the patient and then performing the actual biopsy? That is usually in a non-oncology setting. And still, if it's a pulmonologist who isn't, that connected with a cancer group, you might get brushings and washings still because diagnosis is what they're looking for. And where we have to really change the education is part of the diagnosis is the biomarkers. And
Yep.
so, in someone who's biopsying to check for infection or for other things, biopsy and big biopsy is not front of mind for them. From an oncology standpoint, we think everything is cancer until proven otherwise. And so it's just a different viewpoint. And it still requires education. And so that's why you see that big gap up front. And to Terry's point, you're just not connected to a cancer-centric organization early on. And that's why it's so important to have our cancer centers. I work for City of Hope. We opened a second campus in Irvine in Orange County, the sixth largest county in the nation. Why? Because we want to bring cancer specialty to the regional areas and the communities so that you can avoid some of these educational gaps.
To what extent, from your perspective, is turnaround time and some of the testing an issue as well? Do you think that's a reason some physicians don't test for molecular markers, is because they feel that to send out an NGS test is going to take, maybe a couple of weeks and that's too long?
Yeah, the timing of the test, as we've seen it go down, is still long. It can take a couple weeks to get all the results back. And for some of these results, even speaking as myself as a lung cancer expert, it may take me a week just to digest the results and figure out what they mean if they're not obvious. The other part that is the pressure, if we look at, gap 5 and 6, is again, another drop off there is because if you didn't have the testing done by the time the oncologist sees it, or if the testing was inadequate with an inadequate specimen, oh man, you're going to ask a patient now to spend another week to go get a biopsy, spend another 2 weeks to wait for the test. Meanwhile, you've gotten your radiology tests, and let's say they have, late stage lung cancer that has metastasized. That's a lot of burden to place on a non-specialized expert in a community practice to have to tell a patient, we tried this, it didn't come out the way we needed to. We're going to wait another 4 weeks to undergo this. You've lost that patient. Now, it's different if a specialist tells that patient the same thing because there's a different level of confidence in that. So I think that's unfair for the community oncologist because they're actually trying to do the right thing, but because there's a pressure of the diagnosis and getting started with treatment and a risk, I think they have to move quickly. And this is why I think you see this gap.
Do you hit on something there about the community practice there about, the workload maybe? Do you think that stress, patient load, particularly post-pandemic, has been an issue in how, especially maybe in the community setting, a lot of oncologists think about testing, it's an added stress, they're maybe got, so many patients they have to see, new diagnoses all the time. Do you think that's playing a role, like physician stress is playing a role in some of these issues around biomarker testing and some of the leakage?
Honestly, I see the physician stress both in the academic community and the regional sites. So I don't think it's unique to the community practice. I do think the difference is that if I'm at an academic center like City of Hope, I can make a couple phone calls and we can expedite things really quickly to try and get things done, as opposed to being out in a regional practice in the community where, you have to refer to a different practice to get a biopsy done, and then you have to send it out to a different lab to get that done. Is a little less realm of control and more dependency out there. And so the stress levels, I think, there's a tremendous amount of stress on providers, whether it's nurses, APPs, pharmacists, and physicians these days. And burnout is a real thing. It's not slowing down. The patient numbers are not slowing down, and there seems to be no break in sight, especially when you have to spend half your day typing on a computer just to document so you can actually, get reimbursed for the work that you're doing. So there's a lot of stressors there.
Yeah. Gabe, I want to come to you next, and it's a little bit on this issue of kind of process and turnaround time of testing that Ed mentioned. From a pathology perspective, in the lab, what are you seeing in terms of some of the bottlenecks when it comes to processes and how they contribute to the leakage? I mean, could we empower pathologists to do molecular testing without the oncologist asking for it? That may address some of the turnaround times, or streamline some of the processes. What are you seeing inside the lab?
Sure. So let me say that there are many steps involved in this process, and it's just substantially more complicated for sometimes arbitrary reasons compared to other kinds of tests and services that help to explain why leakage is as bad as it is, and that at every one of these steps, even though there's a name on this slide about what the gap is, the rationale isn't really addressed, and it's far more complicated than it appears. There's a number of factors that include even basic concepts like competitive behaviors or lack of incentive for people to participate in the process that have led to a lot of leakage. And if you look at where the leakage is potentially worse, you'll see that it often there's things that we could always do to address and ameliorate the problem with, but to resolve the issue, to really make a significant impact on leakage, there's not one thing that's going to solve the problem. There's many things that need to be addressed. So in terms of turnaround time, I'll tell you that I will echo some of what Ed said, that there is a major difference between the performance of these things in academic medical center or a large tertiary medical center, where everything could be done in-house, and there's going to likely be very good collaboration between all the parts that are necessary to make this work. That's from getting an adequate material up front to processing things at a facility in-house or an adjacent facility where there's good communication with the ordering physicians and a lack of competition for that material, to rendering the service and then interpreting that service with a knowledgeable party. Ed mentioned as well, I have to sometimes, as an expert himself, I have to sometimes look at this and think about what it means and what is it that, how do I interpret this? I think part of the problem is that the oncologist is interpreting something that's very complex and often not within their expertise. So there's all these things that are kind of broken, and it's significantly worse in the community setting, where things, let me give you examples, 80% of these patients are seen in the community setting. And often these things are not ordered upfront by, let's say, the interventional radiologist. So by the time the oncologist sees the patient, this service has not been rendered. They have to then order the service. That order goes to a reference laboratory. That reference laboratory does not have the material. They have to get the material. Where is the material? It's not with the oncologist either. It's at the local pathology group that may be servicing the local hospital where the procedure was done. They may have their own incentives to share that specimen or not share that specimen, which should never happen, but it happens all the time. Then, assuming that you can get that specimen, you need to rush that work to be done. But that facility has no incentive to do that work in any rapid way, as they're not directly profiting, and profit is a major motivation for doing things in a busy practice, for getting that specimen out in a timely manner. It's got to ship across the street or across the country. That service then, as mentioned before, that specimen may not be adequate. And if it is adequate, the service can be performed. That test result then needs to go back to the oncologist who's going to manage the patient, and they have to understand the results, and they have to make the right determination based on those results. So ultimately, who's interpreting that report is itself a major problem, as where we are today, because of what I think are fairly arbitrary decisions. These services do not inherently come with an interpretation, although they often come with annotation, leaving the oncologist to often order these services looking for things that they're already expecting to see. And if they don't see that, they often get dismissed. I'll also say it's not simply a matter of ordering a test, it's also the matter of ordering the correct test. Many labs offer multiple different kinds of services. Some are better than others. Some are more comprehensive than others. Some are more relevant to any given patient than others. And even making that decision of what is the correct service can be a problem, and lead to leakage itself.
I will add to Gabe's point real quick that ordering that test, I love his comment, because if you check too many boxes, then your tissue will be inadequate, because the more boxes you check, the more specimen you'll need to run those tests, especially if there are some other markers involved. So it is a lot of complexities and ways that things can go sideways.
Yeah.
If I can add one more comment on top of that, the reason why that is itself a problem, right? If we were to start from scratch with our medical system, today, it would be very different than what it is today. We're building something novel here. Precision medicine is something novel, and it's built on top of something that already exists that really reacts very negatively to change. So although today for lung cancer, I would argue an advanced lung cancer patient should probably always receive a comprehensive genomic profile. That one test gives all the information that they need for the management of the patient. Labs are sort of trained by cause and effect of getting reimbursed or not getting reimbursed to prefer to do smaller, cheaper tests that are more specific for, let's say, one gene or one or two genes. And so when you serially test for multiple biomarkers, as I just mentioned, over time, you exhaust the material, particularly in lung cancer, very quickly. Whereas if you had just ordered a comprehensive test up front, you would have had all the answers up front. But there's a lot of other structural problems that make that difficult.
Yeah, and I want to talk to the comprehensive genomic profiling in just a second, actually. But Bonnie, I want to bring you in here and talk about test performance, which is actually highlighted as a leakage point. I mean, you're a leader in the diagnostics industry. You've been in the industry for many years. You and I have actually talked in the past about issues around, many patients don't even respond to certain targeted therapies despite having a positive biomarker test that would match them with that therapy. I mean, to what extent do you think that the current tests that we have to guide treatment decisions are actually fit for purpose? And if they're not, then what does the diagnostic industry need to be developing to make sure that we are developing tests that are fit for purpose?
Well, first, I just compliment, Gabe and the rest of the colleagues here in the panel. I just couldn't agree more with the challenges that are, being highlighted here. And it is absolutely every step of the direction. I've been in diagnostics for 40 years, and diagnostics has always been an afterthought. And it's always been sort of seen as a cost center, which, it is mostly. And it makes it a really challenge to figure out how do we revolutionize, per Gabe's point. We've got to think about a process that is disruptive to the way that it has always been, because the way that it has always been doesn't work in the case of precision medicine. Diagnostics have to be on the forefront, not an afterthought. So how and when do these tests get ordered? And then what do these tests need to be? when precision medicine first, I mean, it's kind of interesting in the patient dynamic and the role the patient can play. I remember several decades ago when a different type of companion diagnostic was brought to market. Simple quantitation of CD4 counts to help in the AIDS, HIV, and AIDS care and treatment. And these tests became broadly available overnight. The patient population was completely educated. They knew what to ask for, they knew what to demand. And that paradigm sort of swept the market across, the world, really, by a wave overnight. Broadly available, bought broadly covered, and bought broadly performed. There have been other testing paradigms, such as HER2/neu for breast cancer testing, because that simple biomarker actually made a decision for you on what drug would work for the patient. But to Gabe's point, the world we're in now is vastly more complicated and more comprehensive. You mentioned touching on whole comprehensive genomic profiling. Well, guess what? We're moving beyond genomics. We're now into proteomics and immunomics and other markers. And so we have to think about, how do we create access to the broadest panel of testing that could be done to inform on the drugs that are available, and then building that 10 years in advance so that when the drugs are available, you actually have the testing available. It's incredibly complicated, and the types of data that are needed to get payer coverage. And I would say the diagram probably doesn't put the level of emphasis that is deserved on how reimbursement creates this drop off, because every patient may be on a different plan, a different health plan in a different state, under different coverage paradigms. Every company or lab that performs these tests may have vastly different levels of coverage, and there's no one roadmap that exists on how all of that can fit together. So the tests need to move toward more comprehensive. You can't just run a BRAF assay or an NTRK assay and have those show up positive on 3% of the patients you test and pay for all of those negative results over and over. So we have to move to comprehensive. The vast amount of progress that is being made in liquid biopsies is really encouraging, because you can take a sample that doesn't require you to go back to that original tissue that is so precious and may not be shared and is going to run out of sample before you get all the testing done. But then the hurdles with liquid become, well, how sensitive is picking up some of these markers in blood? And if the stage of the cancer is earlier, it may even be more difficult. So there really does, need to be a paradigm shift in a lot of these areas, so that whenever the patient gets a sample that diagnoses the cancer, there is an obvious test that can be done at that point in time that doesn't need to wait for the oncologist to order it, so that they have to go find a sample and pick the lab that does the testing. And what lab does all the testing? The answer to that is probably no one right now. And we have to work collectively as an industry to close the gaps on, how do we get to more comprehensive testing? What does that need to look like? How do we get to comprehensive coverage on these things? How do we get drugs through approval that aren't just based around a single point mutation for the companion diagnostic? And all of these things have to evolve and change. I personally think that as we think about roles for AI in the world of diagnostics, these are some areas that I think AI could really be applied. When you think of, you're a doctor in a rural part of America that just got a diagnosis back on a patient you've performed a bronchoscopy on that's positive for cancer, and what do you do next? AI could be a solution to help doctors anywhere help get the next steps that are appropriate done and make these things more broadly to a patient. It's not going to solve all the problems, but there's a lot of problems to solve to make this dream a reality.
Yeah, that's great. And maybe I'd like to come to Ed next. And actually, maybe you could give us your opinion on some of the topics that Bonnie just covered, right? Comprehensive genomic profiling, what does it mean from a clinical perspective? Also, the role of AI, like what's your thoughts on, like, we're moving more towards multimodal testing, as Bonnie said, genomics, proteomics, radiographic information that can be kind of brought in as well. But from a clinician's perspective, sounds great, but what's the reality of that in
Yeah,
medical practice?
yeah, as someone who's worked in both settings, right? I worked in a high-powered academic setting now and previously, and I also worked in a non-university based setting, although a big healthcare system. The pros and cons are back and forth. From a holistic, what's good for the field, would we like to collect as much information as we can on every patient? And remember, this is all about the patient. The patient is our most precious resource, and that is where the center of the universe lies, right? And so everything we're doing is to help that patient live longer, live better, get the right decision. But we also want to learn the most. Our patients who come through are altruistic. They want to help advance science. So from that standpoint, you want to get the comprehensive tests and as much information as you can, just as Bonnie and Gabe and others have alluded, that we can plan for 10 years down the road. Wouldn't it be great to have that information? On the flip side, those reports are less than ideal. And we actually had to set up molecular tumor boards that met on a weekly basis so we could help talk through the results with experts and define the best treatment. I won't say who, what, where, but I saw a report and a physician choose a drug based on the driver mutation because it was an alphabetical listing, and that was the first drug they chose, as opposed to what was the right drug that a expert would have chosen. So these reports can definitely lead to practice gaps, knowledge gaps. And so that's the pros of just making it simple, right?
Yeah.
Putting the drivers, the approved biomarkers with their corresponding therapies front and center. And a lot of the reports have begun to do that. I think that's great. I hear a lot about AI, and every time I do, I go back to the Terminator movies. But AI is something I think a lot of people don't quite understand, or it's jargon that they do. It's almost like the World Wide Web when it first started, several decades ago. But there are definite utilizations for AI, and these are areas where there could be performance metrics put in for interpretation of these to give a best answer. I think that would really help clinicians. It would eliminate the need for long meetings like multidisciplinary tumor boards, as well as these molecular tumor boards, because you could already have a proposed answer and merely validate or not validate. That would make it so much easier than sitting and arguing the pros and cons on every case. I think that can definitely show an application. What AI can also incorporate is helping doctors collate new information and put notes together for them, because we all know at the end of the day, that is the time sink. So if you actually let AI practice the more menial tasks that are being done, you're actually allowing the providers the times with their brain to focus on the thought process of what the best treatment is and those things. And that's where I feel like AI can really help out, is to take a lot of those tasks away or make them much more efficient, because we know that the notes and everything, yes, they're important for documentation, but let's be serious. They're really about reimbursement at this point and justifying what you're charging. And so I don't think the EHR has made us more efficient in those ways at all. So those are the things I think about as we incorporate AI versus machine learning or other types of practices. I also want to come back to this chart and look at the other gap, that was the treatment decision gap. I mean, there's the big fall off there. And
Yeah.
I think both Bonnie and Gabe mentioned that, we didn't include how reimbursement or
Yeah.
insurance practices are. I think that also
It's
doesn't
huge.
really incorporate copays or the cost of drugs, or if you have access to a drug that quickly. Sometimes people have to wait several weeks to get these drugs. So
Okay.
I think there's some definite wins here that we can focus on.
And actually that large drop off is actually incorporates multiple factors, and I think some of them are actually, cost and reimbursement. So that's a big part of that. Terri, I want to come back to you. What's your thoughts on the idea of doing comprehensive genomic profiling? Why not do whole genome sequencing? Why not capture the whole genome of a patient? Is there limits to how patients think about sharing their information? Do you think that patients are open to having whole genome sequencing done, or at the very least, comprehensive genomic profiling?
I think by the time you're diagnosed with cancer, you're willing to do whatever it takes to get a treatment. And as much as the term leakage sounds nice, that's somebody's mom or brother or son or daughter. And those are potential lives lost. And, and so it destroys me when I hear of people that it's like, oh, the doctor did comprehensive biomarker testing, and I push them just in a general, like a Facebook group or something, and they're like, oh yeah, well, I don't have EGFR. It's like, well, what else did they test? Oh, that was it, because the doctor said that's what comprehensive was. Well,
Right.
now they've wasted that tissue potentially. What I don't understand is, why it's not automatically done, right? Why there's not a generally just automatically done. My pathologist is actually whoever this imaginary person is that I never actually meet, that's someplace else, not my oncologist. The pathologist is actually the person that's determining if this is cancer or not. So I feel that it should be an automatic process. Um, I recognize the fact that there's such problems is, we're looking at personalized medicine, which takes a matter of precision, okay, and looking at an individual, but you need a huge amount of information in order to make the best assessments for that. Those 2 points are kind of contradictory, right? But we need to be able to look at it in general terms. I know by the time you're diagnosed or your family member is, your fear is like your doctor, you want them to know all there is to know. I mean, up one side, down the other. Let's not drive this car blind. Let's look at all there is, and let's make determinations for what can be done. AI has potential.
Yeah.
AI should be, I mean, we spend so much time in the doctor's offices from patient's point of view. You walk in, I've told 2 or 3 nurses or people, I've already filled out my forms online, what my problem is, how I'm feeling. They're asking me the same question over and over and over again. Something's getting lost. Why isn't AI being used for that? I know from the doctor's points of view that you guys are being overworked. Okay, you're being stuck with what feels like mundane tasks just to make sure everything makes sense so that you can get paid, and there, it makes sense later on in the effect somebody else can figure out what you did and why you did it. Okay, and we don't even want to go down the litigious society we've got, right? So I understand those are real issues. In the same time, you're still trying to have a real life. Okay. And in the meantime, I'm just out here just swinging for the rafters, just trying to get any sort of a hit to just even get on base, to have any sort of hope. So I think there's a ton of issues, and I know that there's no single issue, but as we can kind of get to the point that by the time you're at a biopsy, I don't understand why it's not automatically taken. It goes through the process, and then at least the patient, gets an automatic report, whatever that looks like. Okay. Whatever that looks like, even if it wasn't enough and it didn't look right and what have you, if I'm getting that, that's going to prompt me to ask my doctor, what is this thing and what does this mean? And here's the next part. It's going to completely save that vulnerability that I have to go, I'm just a dumb patient, and I am just a dumb patient. I didn't go to school for this. I'm just trying to get through this. I'm trying to survive. And I'm going to look at whatever documentation I get, whether it's a CT scan, a PET scan, any sort of biomarker testing, and I'm going to go online and we're going to see what Dr. Google has to say. And if I don't have something to grasp onto, I'm going to be more inclined to pick up every single vulnerable opportunity by every idiot out there trying to sell me some sort of supplement or some other crazy thing that's whatever the latest and greatest is. So if you give me something to hang on to, at least I've got justifiable information to be looking for. I know there's problems, but I know that we can do better, and I know we can keep working at it.
Yeah. Gabe, comprehensive genomic profiling, should it be done just as standard, like Terry said, just automatic? What does it mean from a lab perspective?
Sure. Let me comment on a few things. One thing, your initial question, I don't think really got touched on, which is how come sometimes these tests are positive and patient still doesn't respond? I think one, I'll touch on this a few times, but we tend to want simplicity. I'd mentioned this, right? To make things easy, but real life isn't always simple. Real life is very complicated. What we're looking at in these tests is an underlying mechanism of disease and trying to treat an underlying mechanism of disease. And we identify markers that are associated, and often for very logical, straightforward reasons for why a specific therapy will work. But don't forget, you're talking about an entire organism. You're talking about methods of resistance to treatment. You're talking about other cellular processes that are also concurrent that may invalidate the signature that you've uncovered. And this is a potential hazard of keeping things simple. The reality is, and we determined many years ago now that mutations like EGFR L858R are sensitive to erlotinib. Well, it also turns out that if you pick up a secondary mutation in EGFR, you're not any longer sensitive to erlotinib. And by the way, there's other cell cycling processes that are downstream that ultimately result in cell cycle that is completely unregulated if those things are turned on. And so it won't even matter if you have an EGFR mutation or not. Your tumor will never respond to those types of therapies because these are what we call epistatic relationships. Think about like a circuit board, right? If there's a break in the circuit board, you can repair it. But if you've got several breaks in the circuit board, it doesn't matter what you do in that first break. And so we always have to remember that we're going to make decisions based on the most information that we have. But at some point, things become quite complicated, and we are seeing that. So let's just keep that in mind.
Totally.
And as we have these, comprehensive genomic profiles, you have more information. That I think of this as kind of a equity and equality kind of problem. With the complexity comes more potential for error. It comes with more potential for misunderstanding and misinterpreting, as we heard, from Ed say, see those kinds of things all the time. But at the same time, do you oversimplify something to reduce the potential for misunderstanding, while at the same time missing opportunities for appropriate treatment? If you do a comprehensive genomic profile, you have more opportunities for finding actionable mutations and treatments, but you may ultimately increase opportunity for errors. If you make things simple, you may lessen the opportunity for error, but at the same time, lessen the opportunity for appropriate targeted therapies. Think about having a small EGFR, ALK, ROS1, RET kind of panel for lung cancer and missing 1 to 3% of NTRK fusions because you didn't have it, or having better understanding of the patient's response to immune therapies. So I think from my perspective, comprehensive should be done. But let me add one other thought to this: is we all want there to be appropriate control. We all want to ensure that patients get services that have medical utility. Clinical utility is very important. We only want to pay for, as a payer, I'll speak as a payer, for services that have clinical utility, that have medical value, that can alter the patient management. And often comprehensive profiling gets sort of lumped into this idea of research. But I would argue that it isn't so much research as it is to get all the clinically relevant information all up once up front. And yes, if there's researchy kinds of things embedded in there, that's great. It's not really costing anymore. You have to survey a large region of the cancer genome to do things like tumor mutation burden. I do think that patients should be pushed, practices should be pushed to do more rather than less. It also reduces the opportunity to reduce wasting specimen, right? You get one test up front, you have all the information up front, and you don't have to worry about running out of material, or you're less likely to do so. If I could just do one quick comment on AI, I have one concern with, I have a couple concerns with AI, and I'll just mention what they are. One is, to me, AI is a crutch that's used often for physicians who want solutions to difficult problems and don't know how to get there. And AI is this sort of ambiguous thing in the ether that could potentially solve any problem. So let's just talk about AI as something that could solve this problem. And I think it gets used that way a lot. And the reality is that AI, whether it's a deep learning algorithm or some other type of algorithm that we call AI, is only going to be as good as the information that's put into it. And the reality is that the information that's going to be put into it, if it's to determine whether a patient will respond to potential therapy, is inherently going to be very biased based on all the things we've talked about here. If the patient has mutations that could suggest potential response to an off-label drug, and no patient ever gets that drug because no payer will pay for it, how will AI ever determine that a patient will actually respond to that therapy? Their data will just simply not exist. And the other problem I wanted to learn, the other major problem I want to bring up is that it's one of responsibility. If AI is making decisions, who takes responsibility when it doesn't work? It's not going to be the AI company, right? I think I think there's a place for AI in assisting a lot of things.
Yes.
So I'm not going to disagree with that. Certainly, we talk about decision support, and can AI be part of decision support? But ultimately, the decisions should be rendered by experts based on their experience and expertise. And I would argue the better solution is to ensure that the right person is interpreting the result. And that's something that I almost hear nobody talk about, right? Nobody interprets the report, and then it goes to the oncologist, and then they have to interpret it.
One question to each of you, just really quickly before we wrap, is, what is the one critical thing that you think can really move the needle in addressing the patient leakage that we see in the system? And Bonnie, I want to start with you. What's the one thing that you think can make a difference?
Well, I think the utility of AI to help doctors get decisions distilled to better possibilities based on large scales of data that can be used to build these. I think it would be helpful on the front end of choosing, where do I send samples to get the best, most comprehensive testing. And I think on the back end, as this data all come in, I couldn't agree more, very, very complicated reports, but it's the perfect action for AI to help simplify the reports so that doctors can use their brains to make the final decisions around all the data. And I think it could really be a big step forward.
Ed, what's your thoughts? It's the one thing.
I think we have to provide access. Access is tough right now. There's a lot of barriers to access. City of Hope is going national right now for a reason, because we want to provide greater access to folks. We're going to have access to 90 million patients with our new national footprint. And again, it's about putting the experts working in conjunction with the local entities, the local physicians, so that we can deliver the very best care for that patient who has been told they have cancer. And they will not forget that day. That is a day that they hear loud and clear. Their family members do. And we have to give them access if it means lightening the workloads of our current physician workforce, our provider workforce through AI methods. We've got to do something, but access is a big problem.
Okay, Gabe, what's your thoughts?
I'm going to preface this by, again, saying there is not one thing that will
Yep.
help. All of these things need to be fixed or adjusted or modified and improved. I think, a couple of things spring to mind as kind of quick fixes that could certainly make a difference. One would be to change the concept of molecular testing out of the analytical chemistry data set and into maybe the surgical pathology code set. with the understanding that there must be a physician interpretation as part of the service, because right now that is not the case, and it's one of the major reasons why these tests aren't being well understood. I think those changes could certainly make a quick impact. The other thing I would say is just data integration to make it easier to transfer information from one entity to another, which is where a lot of the leakage occurs. It's not actually captured anywhere clearly on the slide.
Yeah. And then finally, Terri, you, as the patient, the final word.
Oh, yeah. There's so many problems across different parts of this, and whether it's from the testing to the diagnosis to the fact that we've got the cancer. I think we've already kind of determined we can reduce risk factors, but we can't stop necessarily cancer or prevent all cancers. And I think that there's that part of blame. But let me just kind of like throw out there that um, Bill Belichick says it best: do your job. Everybody needs to do their job. And, it's about giving that patient and recognizing the fact that we need to have that information. We need to be in partners in this. And essentially, it's not just leakage at the end of the day. Those are lives. And, and I'm going to throw this out there, that we call those KRAS holes. And that's really what, honestly, that leakage is that's a gap across the board. And if we get diagnosed sooner, we get the testing done, we get the treatment done, but nobody needs to be walking around blind, because we need to be getting it across the board and better.
Yeah.
So.
Fantastic. Well, a great way to end it. I want to thank you all, to Gabe, to Ed, to Terri, and to Bonnie. Thank you so much. It was a fantastic panel. Great to see you all again. And yeah, thank you so much for all your insights.
Thank you.
Thank you.
Thank you. Take care, everybody.